Sedation during colonoscopy is associated with a risk for complications, high costs, and post-procedural activity restrictions and need for escort. Unsedated colonoscopy should be an option at the patient's discretion, but refinement of colonoscopy technique and equipment is necessary for the procedure to be completed at a tolerable level of discomfort. Several trials have shown that carbon dioxide CO2 insufflation during colonoscopy is associated with less discomfort than is air insufflation, primarily because of a reduction in post-procedural pain. Water exchange, a water-aided colonoscopy technique that employs the constant infusion and removal of water during insertion to the cecum without the use of air or CO2, has also been shown to reduce discomfort during colonoscopy compared with standard air insufflation. Few studies have compared water-aided colonoscopy with CO2 insufflation. Moreover, most previous trials of water-aided colonoscopy included predominantly male patients, were single-center trials, or were carried out by few endoscopists. In a paper entitled Water Exchange versus Carbon Dioxide Insufflation in Unsedated Colonoscopy, a multicenter randomized controlled trial, Garborg et al. Compared water exchange colonoscopy with CO2 insufflation in a prospective multicenter Norway and Poland single-blind randomized controlled trial comprising a gender-balanced study population to improve the generalizability of the results. Patients were randomized 1-to-1 colonoscopy with water exchange or CO2 insufflation during colonoscope insertion. Their primary study endpoint was the proportion of patients reporting moderate or severe pain versus no or slight pain at discharge as measured on the VRS-4. Sedation was available on demand. If cecal intubation failed because of severe pain and the patient declined sedation, there was an option for the endoscopist to attempt to complete the unsedated procedure with an ultra-thin colonoscope to ensure the best possible patient care. These cases were considered intubation failures according to the intention to treat principle and were defined for statistical analysis of the primary endpoint as patients having severe pain because pain scores at discharge could reflect the examination with the ultra-thin instrument. Procedural data from the rescue examinations with ultra-thin colonoscopes were excluded from the analysis. The proportion of patients reporting no pain on the VRS-4 were compared in a post-hoc analysis. Secondary endpoints included pain scores recorded in real time during colonoscopy on an 11-point numerical rating scale, ranging from 0, no pain, to 10, very severe pain. The principle of the NRS-11 was explained to the patients before the procedure. During colonoscope insertion, the assisting nurse asked the patient to indicate the highest NRS-11 score after each of the 5 colonic segments: sigmoid, splenic flexure, transverse colon, hepatic flexure, and ascending colon cecum had been negotiated. The colonoscope configuration displayed on a magnetic endoscope imager and visible anatomical landmarks were used to ascertain progress through each colonic segment. The highest NRS-11 score during insertion was defined as maximum pain, and the mean of all segmental NRS-11 scores was defined as overall pain. Other secondary endpoints were the proportion of patients requesting sedation or analgesia during colonoscope insertion, cecal intubation rate, cecal intubation time, total procedure time, post-procedural involuntary anal leakage, yes or no, and proximal and overall detection of polyps and adenomas. The need for external abdominal pressure during colonoscope insertion was recorded, yes, no. Bowel preparation was assessed with the Boston Bowel Preparation Scale. Post-procedural involuntary anal leakage within 24 hours after colonoscopy was recorded on a take-home questionnaire returned in a prepaid envelope, but only at the Norwegian centers. Polyps were removed routinely during withdrawal. Here is a summary of the findings. Background and study aims. Compared with air insufflation, water exchange and carbon dioxide insufflation have been shown to reduce colonoscopy discomfort. However, head-to-head studies of the two methods are lacking. We aimed to compare water exchange and CO2 insufflation directly with regard to pain during primary unsedated colonoscopy. Methods. Patients willing to undergo unsedated colonoscopy at 3 centers in Norway and Poland were randomized 1:1 to water exchange or CO2 insufflation during colonoscope insertion. Patients were blinded to group allocation. The primary endpoint was the proportion of patients reporting moderate or severe procedural pain on a 4-point verbal rating scale at discharge. Secondary outcomes included the proportion of patients reporting no pain on the VRS-4. Results. A total of 473 patients were randomized. A discharge pain questionnaire was completed by 226 of 234 patients in the water exchange group versus 226 of 239 patients in the CO2 group. Moderate or severe pain was reported by 47 of 226 patients in the water exchange group versus 60 of the 226 patients in the CO2 group. No pain was reported by 100 of 226 patients and 69 of 226 patients in the water exchange and CO2 groups respectively. On-demand sedation was used in 15 patients in each group. Conclusions. There was no significant reduction in moderate or severe pain in a comparison of water exchange with CO2 insufflation. The secondary outcome of no pain was significantly more frequent in the water exchange group.